Hi, everyone. We're here for Endometriosis Awareness Month. This is Michigan Organization on Adolescent Sexual Health, or MOASH, interviewing Dr. Kara King from the Cleveland Clinic today. My name is Sarah. I use she, her pronouns, and I'm the communications manager at MOASH.
Hi, my name is Nipur, and I am the MIREC, which is the Michigan Youth Racial Equity Council co-facilitator at MOASH. I go by
Hi,
she, her pronouns.
my name is Amita. I use she, they pronouns, and I'm part of My Voice, which is one of Moash's councils that focuses on advocacy.
Amazing. My name's Kara King. I am so excited to be here. This team is incredible. So thank you guys for the invitation. And yeah, I'm ready to answer all questions that you guys may have.
Okay, so we'll start off by if you could give us a definition of what endometriosis is and how it affects those who have it as a condition.
Yeah, absolutely. Great place to start. Thank you so much for building a good concrete foundation to our conversation. So endometriosis is a really complex disease. So the most simplified terms, it's when tissue similar to the lining of the uterus. So the uterus is made of two different types of tissues, if you will. There's a lining that's glands and stroma, and there's a muscle wall around the outside. So if tissue similar to the lining of the uterus implants outside of the uterus, and that could be anywhere, right? Ovaries, tubes, bowel, bladder, diaphragm, peritoneal sidewalls, ureter, you name it, endo can implant there. If this tissue similar to the lining implants there, it can cause a lot of destruction. The main symptoms that we see are going to be pain symptoms. So painful urination, painful bowel movements, painful intercourse, painful urination, all the things. And this can sometimes just really be in the beginning with periods. And so a lot of my patients, when they first present, will say, my periods are just really bad, really painful, sometimes heavier. But the longer this goes undiagnosed, this can transform into an entire other beast. And what I mean by that is that pain symptoms can really turn into pain in between periods. And it also can turn into a disease that impacts other organ systems. So not only bowel or bladder or ureters, but also the pelvic floor muscles. So it can lead to a lot of pelvic floor spasm, or what we call central sensitization, which is actually rewiring of people's nervous systems. And so this can lead to a disease process that can really be debilitating, severely impact people's quality of life. And the longer it goes undiagnosed, the more pain symptoms that can happen. And the average delay in diagnosis is 7 to 10 years, which is astronomically terrible. This cannot keep going in this way. But up to this point, the longer the delay there is, the more symptoms that people have, and the harder it is to fix and to treat.
Thank you so much for that amazing definition. We talk a lot about what inclusive care looks like, and something with menstruation in general is that it's often a very gendered topic, and a lot of people are left out of these conversations. They're not reflected in research, but that really starts even things that are traditionally known as a woman's clinic. We put around on the Cleveland Clinic website, and we're really pleased to see that the language was very gender neutral. So I wanted to ask, because this is a good example of this, what efforts have been taken in order to make this happen?
I am so excited that you noticed. Thank you, Sarah and team. This is not by accident. I will tell you that. This is very deliberate efforts and very thoughtful efforts by our entire team. So you're exactly right, and it's oftentimes a very gendered topic. And to be absolutely honest, even within the Cleveland Clinic, our institute, we have institutes instead of departments. Our institute used to be called the Women's Health Institute, WHI, up until about a year or two ago, when we actually changed the name of our institute to OGI, the Obstetrics and Gynecology Institute. We took the gender out of it, actually. And we're actually quite lucky at Cleveland Clinic main campus. So we have a lot of hospital systems, right? But Cleveland Clinic main campus is in Cleveland downtown. And we're unique in that we actually don't do a lot of obstetrics at Cleveland Clinic main. And so that has allowed us to be very gender neutral to the best that we can, right? How many times have you walked into your OBGYN's office and there's babies all over the place and pregnant bellies, and I even get uncomfortable. I'm that is not the picture that we oftentimes want to paint, because number one, some patients don't want fertility in the future. But two, endometriosis can cause really severe impact on fertility and cause great difficulty in achieving pregnancy if that's a priority. And so we really have strived at the clinic to create an environment that doesn't feel like that, right? We also care for a lot of transgender patients, and so a lot of male patients here. And so because of that, that also helps push us into this very gender neutral type of setting. And so a lot of training goes into that too. So not only the setting of what it looks like, what pictures are up, what color scheme is there, but also training of your staff, right? Like how do you ask for pronouns, right? She, her, or whatever pronoun people have, that's actually in their online medical record. It's listed right underneath their name. We have their birth certificate name, but underneath that, and right when we're looking at patients, we have the name that they prefer, right? And so without me even having to dive into that right off the bat, which we can and we should, but we also it's on display, meaning it's on the forefront of our mind that these are important topics that we need to acknowledge, discuss, and train everybody around us. So I'm happy you noticed, and it's taken a lot of work to get where we are today.
That is amazing. Thank you so much for putting in the work, and we definitely noticed it, so it's worth it.
Good.
Yeah, and kind of going back to our first question where you talked about that diagnostic delay, 7 to 10 years is insane. That should not be the case. And something that I think all of us have heard a lot about is when it comes to people of color and specifically Black women, there is a huge problem with pain normalization and not being believed to have pain. So how do you prevent that delay in the sense of like reassuring and educating patients that they are the experts in their own bodies? Like they know what's going on with their body. If they're feeling pain, it's pain.
Yes. Thank you. Get on your soapbox and tell everybody that. Yes. And you're 100% true that there is huge racial disparities within diagnosing this, but even past that, how we treat this, right? And even like mode of treatment and open versus laparoscopic and uterine preservation versus not. Like this is so deeply rooted and it's systemic. And the first step in this is acknowledging that and reading about it and educating yourself and educating your staff and your patients. Number one is education. And this starts with like medical students, right? And residents and fellows and staff, like all the way up, that this even exists. From there, I love how you said trust your body, and having a physician who trusts that the patient knows their body better than anybody else. Like that, I think that is so exquisitely important. And I think that if we just stop talking truly and we just listen to our patients, you guys tell us what's going on. It's remarkable, right? Like if you just stop and listen, you guys tell us exactly what's happening, right? Our job is to help make the correct diagnosis efficiently soon in this journey of your disease. And then our job is to educate you in all the possible solutions, possible treatment modalities. But our job is not even to tell you what you should be doing, in my opinion, right? My job is to educate you on what I think is going on, order the correct testing so you can understand what's going on, have me educate you regarding your pathophysiology and future journey, what that looks like, and then give you all the options. And those options usually are expectant versus medical versus surgical. I'm going on a way far tangent, but I'm obviously very fired up about this. So I think part of it is believing your patient. And man, I just can't agree more also though about the systemic, deep-rooted cultural differences in how we believe women or women of color or marginalized women regarding their experiences, right? Mm-hmm. And there's so many reasons why marginalized people have limitations in who they see as well, though, right? Like the type of surgeons that are in their area, the financial restrictions of who they can travel if they want to see somebody else, advocating for themselves in the right way, without making it sound like they're just complaining or these are just normal symptoms, right? And making them feel almost gaslit, like their symptoms aren't real. That forms some really deep-seated medical trauma. And then that oftentimes will lead patients at the next, if they've gone to 3, 4, 5 docs and everyone's telling them that it's made up in their head, a lot of patients are going to feel more depressed. They're going to feel more doubting of themselves. And it's going to lead to this whole cycle of it's hard to get out of, if that makes sense. Mm-hmm. And so I think it's really important for us to advocate for all of our patients, but especially marginalized patients that we see. I think it's important that we build the right tribe of docs around all of our patients, but especially this population of patients. I think it's really important for us to help make things easier if there's transportation issues or financial issues, or getting the right teams involved to help with transportation from different hospital systems. If I need an MRI, but it has to be on the main campus, but I live on the west side, how do we get them there safely and understand that? It really takes a deep understanding of the patients you're working with and the resources that your institution has to build the right tribe around these patients.
Okay,
Did I
got it.
answer your question a bit?
Yes, totally. No, thank you for that. I really liked what you said about like medical education as well, just because I know for me personally, I didn't even know what endometriosis was till like
Yeah.
in college. And if symptoms are manifesting in adolescence and before that, it's so important to know, like you said, about these irregular symptoms and what the condition is in general. So yeah, definitely answered it. Thank you.
Good, good. Yeah, you're welcome. And it's amazing how many, when you talk to these patients, symptoms start in adolescence, like in people's adolescence all the time, right? Like symptoms, when you look back, are like, oh yeah, my first period was like terrible. The first 2 years, like I couldn't even go to school. Like that is not normal, right? Like periods should not be keeping you home from school. That's not normal. And so, yeah, I know you have some questions about probably teenager type things and adolescence and how do we diagnose earlier, but that is exactly where we need to go.
So adding on to like being able to advocate for yourself and like the normalization of pain, how can teens best like advocate for themselves in their personal connections with like family members, specifically parents, and like in also medical spaces, especially like when they're minors and a lot of their healthcare decisions are under like their parents' insurance and such.
That is a great question. And like you think about it, right? Like for me at least, being a teenager was so hard, and I don't have endometriosis. So full disclosure, I don't have this disease, so I can't speak firsthand of it, but I can tell you how hard it was just to live my life as a teenager without all of this. So I can't even imagine the heavy weight that teens can have if this is going on in their lives as well. So I think if I could send a message to our teen listeners, number one, again, trust your body. Like if painful periods are stopping you from doing the things that you want to do every day, it's not normal. And that needs to be addressed. And then from there, I think we have multiple different, you know, groups of people in teenagers' lives that they have to speak with, right? Like you said, their parents, they've had the parents pool of people, but also talking about this with friends can be hard, or the medical profession can be hard. And I think it's also difficult when you go to the physician, maybe the surgeon with your parents, there's probably some things you want to not say in front of your parents. And so how do you navigate like that? Then having the parents there to help support you, but not saying everything in front of them, right? It's a whole thing. It's a whole thing. So I think the best way to really build up knowledge in this population, and I always feel bad saying this, you guys, and the reason I feel bad saying this is because we take a population of people who are already vulnerable, meaning in pain, suffering, and then we're like, oh, but go read about it and advocate for yourself. And you're like, but I'm like in pain. Like I mean, I want to advocate for myself, but I feel bad telling people who are already suffering to like go educate yourself. Okay, so I'll keep that in the back of my mind. But there are actually amazing resources online now. There's an entire endometriosis toolkit. Have you guys seen this? It's through the Women's Health Research Foundation. I'll send you the link. It's beautiful. It's a like 12-page PDF, and it gives a bunch of information for teens of like what's normal symptom wise, what's not normal symptom wise, when should I be concerned, and then it gives an entire beautiful algorithm of how do I discuss this with my parents, how do I discuss this with my school or friend group, right? Like if I'm on the basketball team and now I can't go to practice because I'm in too much pain, how do I actually discuss this with my coach or my teacher or my peers? It also gives an amazing list of questions to be asking your surgeon. And I just love that because sometimes when, or your physician, your primary care doc, whoever you see first, school nurse, whoever it may be, because sometimes when you get into these rooms, at least for me, my mind goes blank, right? Like I forget all my questions and it's really hard for me to sort out and scaffold my brain in a way that feels meaningful. And so this gives a beautiful sheet on questions you should ask. And there's actually also a page for you to write down your medical history in a way that's going to be very helpful for your doctor. Date of your last period. What are your symptoms like? Does it hurt to pee? Does it hurt to poop? Are you sexually active? Does it hurt to have intercourse? Unless you don't want to talk about that. I mean, you can put it all in that. And I think that helps hopefully empower teens or really anyone on the scaffolding needed to talk about these things with your doc. And I think the other important thing that I do for all my teens, I don't know if all docs do this though, is when I see all my teens, I always tell all the parents, I'm going to do some of this interview alone. This is not you or her or him or any of it. It's just every single patient I see, I do 10 minutes alone with my patient, if it feels right, right? And so I think it's also important to carve out that time with your doc if you can, even if it's nothing, right? Even if the parents leave and I'm like, you have anything to tell me? And they're like, no. Then I'm like, okay, that's okay. But sometimes they're like, yes. And whatever they have to tell me is really important. So I think also just somehow finding a doc, finding a surgeon, finding a team that values your opinion alone in case there's things you don't want to say in front of your parents is also really important. I talk fast. Are you guys okay?
No, thank you. We had so many questions, but I'm glad.
Okay, good.
It sounds amazing. And I think I speak for all of us when I say like we would love the link because we had not been made aware of that. So that's awesome.
Yeah, for sure. I'll send it to you guys.
Perfect. So we talked about, and you touched on this like perfect flow of conversation, the self-advocacy. And we've talked a lot in our social media posts these last few weeks about endo, how a lot of patients do visit. Like you said, many doctors get told they don't have it. There's this level of gaslighting. And the bad news is that's awful. The good news is there are these like resources that have come about. You know, there's Facebook groups, there's books, there's podcasts, there's documentaries that all have this great information. But that being said, we want to know essentially how the self-advocacy can potentially work in the patient's favor, but how does this also build on communities that have been historically harmed? So when we think about self-advocacy, like you said, there's this certain level of like having the mental fortitude to believe like, no, I know myself and I know better than like, you know, I hate to say it, but like the doctors in this instance.
I know.
So yeah, I would love to hear like who you see that kind of has that ability to like continue trusting themselves and what populations maybe are more likely to just be like, well, I guess that this is what it is.
This is a great question, and it's there's no clear, concise answer, unfortunately. I always just want to tell my patients though, if anyone ever makes you feel small or makes you feel gaslit, this is on them. Like 100%. This is their insecurities. I'm not kidding. So if a physician is telling you, oh, this is just normal period pain, or this is nothing, this is in your head, or you're just depressed, like get some more sunlight, or whatever the heck they're telling you, this is not on you. This is 100% on their knowledge deficit. Like they literally don't know what they don't know. And that's unfortunate. And I don't know if that gives my patients any, I don't know, confidence or bravery to understand this is not on them. It's on the patient. It's on the person telling them that. I don't know if that's helpful or not, but I always just want to make that clear. If you go to the right surgeon, they should never make you feel like that. And that goes down to even asking vulnerable questions like, what's your case volume, right? If anyone's ever offensive to what's your case volume, you should not be going to that surgeon, right? What's your complication rate? If anyone's defensive to that, you need to be going someplace else, because these are questions that I very much value in my patients. That to me tells me that they're very well read and they're being very thoughtful and they're choosing me. They're not just stumbling upon me to do the care that they need. And so if you ever ask a question that's just asking out for your safety and you're not made to feel like embraced by that question, you're with the wrong person. Yeah. So in regards to like when can advocacy be flipped? Like when can self-advocacy feel worse? You know, I think it goes down again to our like marginalized patients who are repetitively not believed, right? Or not valued, or are oftentimes more complex. I'll be honest, in that because they haven't been listened to for so long. By the time I see them, they have so many other comorbidities that they're more complex patients. They're in a more serious condition because of central sensitization or pelvic floor spasm or endo that's not going through their bowel or bladder or ureters, or now they're in a much worse fertility standpoint because no one's actually treated them for the past 10 years. And so I think it's just really important to find the right group of providers that are going to listen to you and give you the care that you need. And if you're in a scenario where you're not being heard, then there's amazing online resources on how to find endo surgeons. AAGL is our national society. Our MIGS fellowship is run by AAGL. We're a huge advocacy group, not only for endo itself, but also for patients. At our annual meeting every year, we actually do patient-centered advocacy forums where we have surgeons speak to our patients via Zoom. It's free registration. We have an entire listing of the MIGS docs in your area. You can put in your zip code and there'll be a list of MIGS docs that are in your area. We can also connect you with the right, like for instance, pelvic floor physical therapists. So there's a lot we can do actually virtually and online if you are in a setting where you don't actually have someone right in your city.
Amazing. That's so helpful. Thank you. And
Yeah,
when you do say those things to patients, I do think it makes a difference.
thank you.
So kind of building off of that and just knowing about endometriosis in general, I'm sure like we've talked about throughout this entire conversation, probably plays a whole gigantic role in being able to self-advocate and in being able to talk about this. And I know that you explained what endometriosis is, and I know that I mentioned that I actually had no idea what this was till a few years prior. So for those, and that too is out of my own, like, okay, I want to research this because this is what I want to go into. But for those who aren't seeking that medical education and who aren't as medically educated, how can they learn about this topic outside of the conventional ways, or like is it something that should be implemented in schools?
Yes. My answer is yes. For the love of God, people, yes. Like, it's just crazy the disparity in women's health research, for one, research money going to tracking this disease. I could go on forever just about all the things, right? Like ICD codes is really how we track diseases, and we've only had a very limited number of codes for endometriosis. We just expanded it to like 7 pages of codes, and that's going to help us get more traction in regard to research money, which then funds for education efforts, right? And training all the people. So you nailed it, though. Really fantastic question. You nailed it. I think this really starts educating nurses in schools, to be honest. Like, this is where a lot of this comes up. I'm going to say is nursing, like nurses in schools, as well as emergency room visits, as well as primary care docs, right? I'm thinking about like who do our adolescents typically go to first? It's usually not gynecology. Sometimes it is, but oftentimes it's either the emergency room because they're in tons of pain. They think it's appendicitis, or it's school nurse, can sometimes happen, or just their pediatrician. So I think starting in all of these avenues is going to be really, really beneficial. But I'm even thinking about like this training even needs to go to our general surgeons, right? So if anyone ever drops a scope, whether it be for a gallbladder or an appendix or anything, they should always just scan for endo. Just look for it for me. Just like look and take a picture. So like I think this permeates all different fields of, again, just diagnosing this earlier. I think the other aspect, though, is us working on ways to diagnose this outside of surgery, right? So right now, gold standard historically has been dropping a scope, finding endo, taking a biopsy, excising it, and looking at it underneath the microscope. Holy crap, that's so invasive, right? Like, there needs to be a way that we can diagnose without doing that, whether that be a serum blood test or et cetera, right? Imaging. And so I think with Jill Biden just allocated what, $100 million towards women's research funding. This happened just in February. And so this is going to change a lot for women, because we're going to get more research money to diagnose things sooner and earlier. But I would say in the meantime, MRIs, ultrasounds, the better imaging that we're getting, the sooner we can diagnose it as well. And so I would say starting young, and then from there, in regard to surgical education, we need much more robust curriculum for our medical students, our residents. Our fellows are getting it, thank God. That's why I did my fellowship. But we need to start much younger, and so we're diagnosing it sooner. That's really what it comes down to.
Yeah, definitely. I agree. I've heard some recent things about using actually AI for MRI diagnosis, which has been really interesting, as well as like samples of menstrual blood. So yeah, a lot of like upcoming research, which
Yeah.
I'm excited about, research
Yeah.
that probably should have been done sooner. But yeah, so I completely agree with everything that you said.
We'll take it though, right? Like should have been
Oh
done
yeah,
sooner, but we'll take it.
definitely. Yeah.
Give it some attention, people. Yeah, exactly.
So adding on to like how people can advocate for themselves, and like
Yeah.
how healthcare providers can like try and implement things that are more inclusive and like more like straightforward in like speeding up the process of diagnosis, what are like systemic things that need to change to make sure that providers are like up to date on um, like recognizing symptoms and like being able to prescribe the correct treatment? And like, what does the current curriculum look like? And like, what's its strengths, but what is it like also lacking? And also, what made you want to focus on endometriosis specifically, and how did you pursue the training in this area?
Yes. So I'm hearing a lot of great questions in that. That's loaded. I love it. Let's get to the bottom of that. So I think, what does the curriculum look like right now? It's a great question. Man, I could go on forever about this. Okay. So in medical school, you ready for this? There's some, okay, granted, I went to medical school like 500 years ago, but when I went to medical school, some were like systems based and some were more like organ based. Is that still the way it is? Nipur, is that the way it still is? Do you know anything about medical school yet or not quite yet?
I'm not in medical school yet,
I
so
know not
I'm
yet,
not
but
sure,
you
but
know,
what you're saying sounds right from things that
yeah,
I've looked up on websites, but I'm
yeah.
by no means an expert on that.
Sorry, I'm going to pull you in. You're closer to it than I am, for the love of God. Okay. But I did go to Michigan State Medical School, best school in the world. Just going to throw that out there. So we were systems based. So I was like, we're way ahead of the curve, right? So system based to me felt really good because it like ties in different organ systems to different pathologies. So we usually get like a unit on like GYN type things during medical school, which is helpful, but it's medical school. You're kind of memorizing stuff and you're taking like multiple choice questions. Okay, so that happens. And then you get to residency. And depending on what your residency is, you may get most of the time zero knowledge about endometriosis. Meaning, if you do a residency outside of OBGYN, if you do a gen surge residency or whatever, any other residency, oftentimes you won't even get any endometriosis type of curriculum, even if endo is impacting those organs, right? So I do a ton of colorectal, rectal sigmoid disease every single week, ureter endo every single week, bladder endo every week, diaphragm endo every week. So this can impact all of the organ systems, but very rarely do they have any curriculum in that. So that's that. But then we get to OBGYN, where we should be like the most knowledgeable, like we should know everything. But let me give you the window into OBGYN residency. So OBGYN residency is 4 years long. And in most residencies, it's very obstetrics heavy, very obstetrics heavy. So in most residencies, you're only getting about 18 months of GYN, and the rest of the time you're actually getting obstetrics. So think about that. It's pretty wild. Cleveland Clinic is we were the very first tracked residency program. And what that means is for our residents, each year they have X amount of weeks that they can track and do whatever subspecialty or specialty that they want. So if you go to the Cleveland Clinic for your residency and you track all of your tracking months into a GYN specialty, it becomes pretty even or even more GYN than OB. This is exceptionally atypical. Cleveland Clinic and Swedish are the only two systems in the country that offer tracking. So if you think about it, if you're going to a residency program who only does about 18 months of GYN, and that's to learn all of GYN. I'm talking about menopause care. I'm talking about HRT. I'm talking about inpatient. I'm talking about outpatient. I'm talking about simple surgeries, complex surgeries. I'm talking about hysterectomy that can be done vaginal, laparoscopic, single port, open, robotic. Like that is not a lot of time to learn all of the things. And so that's what really pushed me to want to do a fellowship, right? Because I was like, I want to be really good at this. Like, I don't want to be like dabbling. I'm not a dabbler. I'm either going to go 200% in or 0% in. That's why I keep wanting to have more dogs and more horses. My husband's like, can we stop going in 200%? We have enough dogs. But I want to go big, right? And so I want to be really good at this. And so that's what pushed me to want to do the minimally invasive GYN surgery fellowship. Then you get 2 more years and mostly just this. But if you think about it, that's not a lot of the population of surgeons that have the knowledge of endometriosis that our patients deserve. So with that being said, MIGS fellowship is one of the top sought off fellowships every single year within OBGYN. People, meaning OBGYN residents, definitely have the drive to learn more about this in their field. I think if you're lucky enough to do a residency program at a place that has a mixed fellowship, you're going to get a lot of this anyway. Like my OBGYN residents know endo. They will know endo inside and out when they leave, but not all programs are like this. Which then leads me to this entire mission of surgical coaching and really trying to build an endometriosis collaborative. So this is my hot off the press current mission with a group of top endosurgeons in the world right now. So there's a group of us trying to create an endometriosis collaborative that basically gives standards to how endometriosis is being surgically treated and medically treated, but primarily surgically treated. So how do we actually develop best practices? How do we really define excision? How do we define what full excision looks like? How do we really look at outcomes, right? Because endometriosis research is really hard because there's a lot of different ways to do our surgeries. And if you're not doing the best care, then your outcomes are going to be different. So how do we actually delineate that? And so this is a very long-winded answer of fellowship's important. And I think we need to develop standards for surgeons out there that are already graduated and how to improve their skill, because there's not enough endosurgeons that are available at the current moment. So we need to do our best to create more, educate more, and then take the surgeons who are already out there who want to learn and do more to give them the scaffolding to do that through video review, through video coaching, through mentorship, through all those things. Did I answer your question?
Yeah, it did. Thank you for that very in-depth answer. But I think it answered everything.
That's amazing and so exciting. It sounds like there's good things coming, even if historically this has not been the best. It seems like maybe things are changing.
100%. We're no longer an afterthought. Women,
Great.
no longer an afterthought. We're done. We're done in that position.
That's very exciting to hear. And then, so it sounds like you've kind of already answered this, but are there any other advocacy efforts in this area that you've been a part of, seen, and what successes? So that can be like from the medical side, that can be from the patient side. I believe you've mentioned Shannon Cohn before and like below the belt and things like that. Yeah, we'd love to hear.
Yes, there's so much advocacy going on now, even from the patient, like from the patient side of things, which I think is changing the game, which is amazing. I think social media has actually been an incredible addition to all of this in good and bad ways, right? Like social media, there's bad information out there, but there's also a lot of really good information out there. And I think the more we can pull people in, and I always call it like a tsunami wave, right? Once we can pull people in and like together move forward as a group, as a coalition, as a collaborative, like that's how real change happens. I think Shannon Cohn's amazing, right? I podcasted her. She is one of my heroes. She has incredible documentaries that she's put out. Her second one just got released not too long ago. She has amazing school nurse initiatives for starting for young kiddos. She has amazing videos, movies that are out that for sure you guys should watch if you haven't, or use that to spread good information. I also think there's a lot of advocacy going on at the Hill. So people, surgeons, physicians actually going to the Hill and speaking with congressmen and actually changing the way research money is being allocated. For instance, again, Jill Biden's big women's health initiative push, where she put forward $100 million for women's health research. That's going to make a really big difference. The other part of this is I mentioned earlier ICD codes, and this is going to be crucial in reimbursement. And we think about reimbursement. This is not me being reimbursed. This has nothing to do with me. This has to do with like the disease itself being reimbursed for the hospital. Because the truth of the matter is women's surgeries, so surgery on people with uteri, I don't mean to not be more gender neutral, we make nothing, meaning we have no reimbursement. So if you have the same code, surgery code for a female versus male, like a biopsy of a labia versus a biopsy of a scrotum, totally different reimbursement. We get paid nothing. This stuff will fire you up. You'll like be livid. If the more you learn about it, the more livid that you'll get. And there's Louise King is one of my really great friends. She's in Boston and she has an amazing paper about the double discrimination, how OBGYNs in general, there's more women OBGYNs and we're treating women patients. And so this double female women gender makes us get even less. It's infuriating. So with all this being said, the ICD codes is translating to hopefully better tracking of the disease, which is then going to translate to more money being allocated, hopefully to women's health, right? And that's going to translate to all the things, research money, OR allocation, like even like how much OR time I have, right? I mean, my patients know I am booked out 8 months for surgery. It's infuriating for my patients. Like I feel so bad. People come to me suffering and I'm like, great, I'll see you in November. It's like, are you kidding me? But we need more resources in order to do everything else in the system. I say those are the big advocacy efforts that I'm personally a part of most recently. But I think a lot of the national societies are having really great efforts being put forth. And then again, a lot of these different patient advocacy groups have also done tremendous work out there.
Amazing. Thank you. That is so helpful. And I think I was reading something about the IDD codes. Was that just changed in like 2022? Like super. So
That was a 3-year project. Ted Lee and myself, my fellowship mentor and I, we like teamed up with CDC and all the important people. Yeah, so it was a 3-year project, and it just got pushed through.
have you been able to see like data from that yet, or is that like that feels maybe too quick?
Not yet. Yeah, soon, hopefully. So the next step is to get people to use it. I'll be honest, I'm like, they exist. Now the surgeons need to log it. So that's where I am. But hopefully soon. We'll have some real numbers soon. That's what I'm pulling you in for some of my research. Help me get these new ICD codes and help me push all of our coding forward.
I love it.
So you talked a lot about how like physicians and other people can really advocate in getting this information across and getting more funding. How can people who may not be directly medically involved, like us youth here, people in general, that are just really passionate about this topic, like what type of advocacy efforts from these populations are the most effective in getting information across to people, especially on a larger scale? Like I know you touched on social media a little bit, but yeah, I would love to learn more about what we can do and everybody watching this can do as well.
Yeah, I love how your brain's like action items. I want to be like in the trenches and give me like tonight, what can I do? I think that's brilliant. Okay, great. Where can we start? I think like starting small in your community can go really, really far. So I know I oftentimes think like I want to make a change that's like world changing, which we all want. Together we will do. But I think even just thinking small in your community can make a really big difference. Meaning, can you reach out to the local schools, right? And let them know that these endometriosis toolkits exist? Can you share Shannon Cohn's documentaries, right? Even just starting small like that, like all these summer camps that are going on right now, just even reaching out to these different groups and just spreading the news there, I actually think can make a bigger impact than you'd even guess. Um, Moving on to the high school population and just educating these patients again around birth control, number one, and endometriosis, number two, I think can make a really big difference. That seems really small, but it can feel really big. And then the other thing is reaching out to these different national organizations, right? So again, the national societies, there's AAGL, there's ASRM, which is for more REI type pathologies, which has a lot of patient advocacy groups within them, or even some of the smaller ones, even like Girls on the Run. Like I think about Girls on the Run is my personal favorite. I'm a runner. And so reaching out to these local organizations and volunteering for them. Again, I'm a runner, so my brain goes there, but I will run marathons and sponsor endometriosis funds for that. So doing different fundraising for whatever you're already doing anyway, make it a sponsorship thing for these different groups, I think can be really helpful. Or just like you're doing, if you are going into medicine and you're thinking about being a medical student, which you're going to be, reaching out to people that are doing this, we will pull you into our research, we will pull you into our world, and having people on the ground help us actually disseminate or do some of the like data entry things, which may seem small, but can make a really big difference in getting big publications pushed forward, can make a big difference. Yeah.
No, thank you for that. Yeah, I think it's just really exciting to hear that people that aren't like super advanced in their careers or at my age, like I'm just a 21-year-old girl. But I'm excited.
Oh my gosh.
It's exciting to know that like we can be involved and like definitely really make a tangible change in these systems, and seeing and like raising awareness about this condition like we're doing here today. So yes, truly, thank you for that.
Yes, you're doing it. Look at you guys. I'm like so honored to be in your presence. Like you guys are the ones changing the world. Like truly, you guys are the ones that are on the ground making a difference. So I'm honored to be around all of you guys.
Sarah, should we like continue or should we do the
We can do the wrap-up question. We kind of touched on all our other questions. This was perfect.
Cool.
Stop and wrap up. We'll have a few minutes and be perfect on time.
So for our final question and to wrap everything up, what are some ways that we can best support those in our lives with endo?
Oh, another really great question. Mm, I'm going to keep it simple again. And man, I am just such an advocate of being present with people and listening for the sake of listening. I just feel like this gets lost in the shuffle of life. And I think being present with someone who is potentially suffering from this and truly listening to people who are potentially suffering from this can make all the difference in the world. So, number one, I would say giving your time to someone. And I mean, truly giving your time, like flipping your phone upside down, taking off your watch that's buzzing, like looking at somebody and having nowhere else to be but with that person, I think is the most powerful thing in the entire world. I know it sounds so small and simple, but I just want the people that I'm with to always feel like they're the most important person to me at that time, because they really are. And I think if you treat relationships with that type of importance and gravity, then it shines and it makes a really big difference. So number one, just listening, being present is number one. Two, I think, like I mentioned earlier, it's really hard for patients who are already suffering to now all of a sudden advocate for themselves, think of the right questions, ask the right questions, take the right notes, right? Like everyone, people are like, just take notes, write the questions. But like if you're in pain and you're suffering, your brain is not going to be as sharp as it could be because you're probably not sleeping, you're not eating as well, you're nervous, all the things. So I think the other part of this is if it's within your resources and you're able to do this, is help them find these different resources that we're talking about. And I'll send you some of these toolkits that I'm mentioning. And that's going to help scaffold their symptoms, scaffold their questions, make them feel that their symptoms are justified and they are real. And then if you can accompany them to medical visits, if you're like in that type of space, I think that's so powerful. Even if you're not going into the room with them, right? Like even if you're just driving them and sitting in the waiting room, I really think that makes a huge difference. Some patients like to come with a friend or their partner or whoever. Some people don't. But I think it just means a lot to have someone like sitting in the waiting room, caring enough about the situation that you're there for them. And then we could go on and on. If someone is going under surgery or not going under surgery, that's a whole other list of things that you can do for them to support them in that time. If someone is going through surgery, the post-op can be really hard. People can take sometimes a few days, few weeks to recover. And so I think not asking what people need in that time, because most people are like, I don't need anything, right? I don't want to ask for anything, but just like doing the things, like dropping off food, ordering food for them, doing the things without asking what they need, or asking what they need before they're in the situation of needing it, I think can be really helpful as well. What do you guys think? What am I missing? You guys are so wise. I feel like I should be asking you these questions.
Oh, thank you.
Sarah?
Anything. I think that was really good. We've talked a lot about like we put together a resource guide and like sharing that with people, because I think especially teenagers, it's kind of like there's that like complaining to friends like, oh my gosh, my periods are so bad. So having the like knowledge ourselves and like the importance of everyone being like notified of this
Yeah,
and stuff, because it's like, yes, statistically like 1 in 10 people with uteruses, like we guess this, but like also like even if you don't have endo, you will know someone who does, and being able to say like,
yes.
hey, like you can tell me to like stay out of it, but like this sounds like this thing I heard of, can I send you this article, is like a huge deal.
I love that. I love that. Like not being overbearing, but then just providing the resources. And I've noticed that even if people are like, I'm all set, I don't need anything. If you just open it up to them, even if they don't ask you for anything, then if you just open it up to them, they go home and think about it, they sleep on it, and they oftentimes will circle back. I just think words matter. You know what I mean? I think words matter. So even if they don't ask for your help at that current moment, it did something. I believe in that.
Absolutely. I'll go ahead and stop our recording and we can wrap up, but this was so good. I'm so excited to share this with everyone.
Good.
Thank you so much again.
You're welcome. Did it hit all the points that you wanted? Do you feel good about it?
Oh, how are you two feeling? So
Pretty
much.
good.
Are you
Yeah,
happy?
that was really good. I was kind of just sitting there in awe the whole time and low-key typing some notes too, because I'm like, like it's just what I want to. No, I love it. Like it's genuinely just what I want to do. So yeah, like
That's awesome. I have the best job. I'm really lucky to do it. So if this is for you too, man, come on in, join the party. It's a lot of work, but it doesn't feel like work, you know, like when you really love something, it doesn't feel
Oh,
like it.
exactly. Yeah.
Yeah.